Thank you for these wonderful talks. I had two questions regarding the radiological follow-up after treatment. So the first one, as Dr. Carlton-Jones said, if there's no spinal epidural fluid left radiologically, then we are happy. And we also know that, and this has been touched upon, that some patients remain symptomatic after treatment of the leak. I sometimes have difficulty convincing my patients that the leak is closed because they're still symptomatic. And I usually do this by repeating the spinal MRI, and if the fluid is gone, that's for me the reason that the evidence of the leak has gone. But do you think that normalized spinal MRI in SLEC-positive patients is sufficient to prove the leak is sealed, or do you do repeat myelograms in these persistently symptomatic patients?
Is this on? So that is a great question. I think we do have a proportion of patients who are still symptomatic even after surgical repair, who don't have fluid radiologically, and we will do myelograms for these patients and we don't seal it. And I think that has been the experience of some other centers, that sometimes patients can get better initially and then they become symptomatic again. But I think, you know, as a radiologist, the best tool for excluding a leak is myelography. And so sometimes we will do that.
Next
so
question.
we try to, we get an MRI on every patient within 48 hours before they're discharged from the hospital, at least after surgery, right? For any type of leak that's caused by a dural tear, right? So ventral, lateral, dorsal. Of course, not everybody wants to do that within 2 days of surgery, right? That back hurts. So, and then we get it when they get home. And I think MRI is really, really good for looking at extradural fluid. If we're still convinced that, there's a chance that they're still leaking, then we will repeat a digital subtraction myelogram. But I can't really remember anybody who had a leak after the MRI was normal. Can you? Yeah. And then, for CSF venous fistulas, of course, it's a little bit of a different scenario, because to make certain that that's gone, you have to do another invasive procedure, because we don't have non-invasive imaging looking for CSF venous fistulas. So if we feel that, there might still be a fistula, then we would repeat the invasive myelogram. I know that, I think Dr. Mamluk, who's here in the audience, he routinely does invasive myelography to make sure that the fistulas that he treats with fibrin glue injections, that they are completely gone. Isn't that right, Dr. Mamluk?
We used to start off with post-myelogram after patching, but then now we typically use MR brain just as a surrogate. But if there is a question, like as you mentioned, like if the high concern for recurrence, then we'll do a follow-up myelogram.
Thank you. My other question was about the reverse scenario. In some patients, I've seen that they had very good clinical results with patching, but then their spinal MRI after 3 months and after a year still has this large epidural fluid collection, and it does not resolve. And I am convinced that these patients still have a leak, but some of them really are symptom-free. And because of these worrying long-term consequences, the superficial siderosis, I doubt, should we still refer those asymptomatic or oligosymptomatic patients for surgery to definitively close the leak and to avoid these long-term complications? And if not, how do you follow them up? Do you do a yearly MRIs, audiograms, stuff like that?
Yeah, we published a couple of articles about, the long-term risks of developing, one or more of those complications, particularly in patients with ventral leaks. And the vast majority of those had no symptoms anymore from their leak, or just very minor symptoms. And then after 15 years, right, so if you have ventral leak, after 15 years, there's about a 50% of having developed superficial siderosis. The risk of spinal cord herniation is about 10%, and the risk of this bibrachial amyotrophy is about 10%. As Dr. Brouwer, showed this morning in their series, I think you said like 10, 20%. Oh, right, you're sitting there. 10, 20% of patients either just had a history of a headache or never really had a headache that they remember.
That's correct.
Yeah. So if it's somebody who, is fairly young, right? Let's say less than 80, and they have a persistent leak, then I do recommend surgery for that, just because we know what the risk is of developing these complications. We know that the risk of surgery is relatively low. If for some reason they prefer not to have surgery, then we get yearly MRIs to look for superficial siderosis. We, more or less carefully explain to them what symptoms to look for. And I think your idea of doing, maybe yearly audiograms is a really good idea as well.
Have you had any cases of lateral type leaks with longer term complications such as siderosis? Because obviously in our paper we didn't see that. So I do agree that the most important follow-up in these dural tear type leaks of any cause is the spine to see if there's still fluid there. But I'm interested to hear about his experience.
Yeah, we haven't seen anybody with a lateral leak develop superficial siderosis, and we think that might be because when you have a ventral leak, right, there's an epidural plexus there that's a really robust epidural plexus, so that tends to bleed more. I think we have really no scientific proof for that. There's some type of calcification that might injure the vessels there that prevents that from clotting. We now have seen a few dorsal leak patients with superficial siderosis, and you also can get superficial siderosis from CSF-venous fistula. So that means that it's not just one direction. It's not just from CSF space to vascular space, but you also can get flow from vascular to intradural space.
I think we have one question from the audience.
We see patients after neuraxial procedures who have PDPH, and we typically, in anesthesiology, we typically treat them ultimately with blood patches, sometimes a second blood patch. Fortunately, most of them get better, but not all of them. When should we be referring them to you?
So I have to take this difficult question, okay? We don't know. And these patients that are reluctant to the third or second or fourth epidural blood patch usually end up sometime in our service in a specialized center. We do extensive imaging, and really basically we do not find anything that we know how to handle. There's this dinosaur sign. We don't know the sensitivity and specificity of it. We find rarely you find findings that we can handle. And there's one exception. There's the needle punch through both dural layers, also to the ventral side of the dura. In these cases, you almost ever see a ventral slag, a small, tiny ventral slag. Then we are happy because surgery is easy, straightforward. We close it and the patient is fine. In a non-shot through ventral leak, post-dural puncture patient, it's difficult. And then we have the group of patients that end up with surgery. And surgery is not dangerous, it's easy, it's extradurally, and we almost always find something, but it's difficult, sticky membranes, a lot of vessels. We are happy we can remove, but then still patients only improve in 60, maybe 70% of the cases. So difficult cases, we are trying to write this up, to work this up, to build registries. I don't have a definitive answer, but only shut through ventral leaks, this is straightforward. close it, and patient is fine.
So going back to the previous discussion, Dr. Carlton-Jones, you mentioned that there is increasing experience and evidence of sort of serial CSF venous fistulas, that you patch one, you find another, which to me raises the question of whether after the initial procedure, there's some role for pressure testing, that should we be looking for a way to identify other weak spots? Is there any experience with that? What's your opinion of that?
I would say that we have found more of these. I'd say probably my mylos are a lot better than they were several years ago. So maybe that's why I'm seeing so many of them. Speaking to a lot of other people at other centers, I think that is also the experience. And it does raise the question, what is physiological for that patient? When we have these multiple CSF venous fistula patients, we don't treat all of the fistulas. We treat what we think is the biggest. Whether that's right or not, we don't know. But that's the question that I raised in the end, which is, if these patients are going to keep recurring, are we going to do 5, 6, 7 embolizations or bone removal? No matter, even if it's a really tiny hole, it's still bone removal. And maybe we need to tread gently with some of these patients. This is not all, this is just some patients.
You make that sound like, oh my God, there's some bone removal. I think endovascular embolization, right? When you see those pictures afterwards, like the whole not the whole venous system, but so much of the venous system is gone, right? It's full of this onyx. There's no flow going through it. And I think, Dr. Mai, I think that's the reason why there's probably a higher frequency of rebound, because you just got rid of part of your venous system that absorbs normal spine fluid. But I recommend patients who have had a recurrence somewhere else along the spine, I tell them either they can take lifelong Diamox, right? Acetazolamide. Most people don't like that because that has a lot of side effects. So they can take a homeopathic dose, right? Especially here in Europe, people are very much into homeopathic medicine, even in veterinary medicine, actually. So they can take a homeopathic dose, or they can drink some dandelion tea. Dandelion tea is a really mild diuretic, and that's much better tolerated than Diamox. We've been looking at some, if there's a relationship between compression of the internal jugular veins or any kind of venous stenosis, that those patients might be at higher risk of a recurrent leak. But the follow-up of that has just been a year, maybe 18 months. So maybe in the 2035 leak session, we'll have some results of that.
Thank you. Then one more question from the audience.
Hello. After a blood patch, some patients will improve immediately, and some patients do not improve and there are symptoms immediately that tend to wait days or weeks before improvement, or do not improve at all. In your experience, do you have a delay until to consider after a blood patch or any therapeutic procedure until considering the failed treatment? In our experience, sometimes we wait a month until considering the failed, but maybe it's too long. And what is your experience about considering the failure of the treatment?
In my eyes, they should improve immediately. If they do not improve immediately, something is wrong.
Even some people, but immediately you mean 1 day, 2 days, or
1 day, next day. Yeah.
Okay.
Another question.
Thanks all the speakers for their excellent talks. I'm originally from South Korea, and I have one comment and one question. My comment is on the application of the ICHD3 expansion by the Dr. Brower. Actually, the ICHD has no fault because the purpose of the ICHD is classifying headache into secondary and primary headaches. And we apply this to patients with headache. And if the patients have a headache and patients with some kind of disorder, we classify if this headache is attributed to this disorder, is it the purpose and structure of the ISHD. So it contains a headache in the first line, but it's not for diagnosing SIH itself. So please don't be confused by it. And my question is to Dr. Carlton Jones. Do you recommend the fibrin sealant patch over as a kind of first line to like patients with ventral defect over the blood, or do you think it's a kind of second line after blood patching?
I don't do any blood patching for fistulas. I don't think that they respond. I don't do any non-targeted blood patching really at all when we know what we're going to find really. I think non-targeted blood patching has a role in certain patients, like very sick, unwell patients, brain sag dementia patients where we can't find the leak, and some post-dural puncture patients. For fistulas, we know that we're going to find a fistula most of the time. So we have already had this discussion with the patient as to what the available treatments are. And then when we find the fistula, we can offer this the same day in not all, but a majority of patients. And some patients say, no, I don't want to do that. I want to go straight for a surgical repair or a transvenous embolization. And that's fine. We work with the patient for whatever their wishes are. But most patients, at least in the UK, want to have fibrin glue injection.
Can I just step into this question of blood versus fibrin? Isn't it just the compression of the vein that causes the leak to close? So could be blood just an option when you are scared of using fibrin in this location?
That's a really great question, because we previously used to think, well, you want to get glue in the vein, but actually in our study we showed that glue in a vein was not a predictor of this, and I don't think that that's actually we're not aiming for that. We think that it's more likely actually to be compression and induced venous stasis resulting from that. So yeah, possibly.
Is there one more question here?
Hello, thank you for the excellent talk. I have a question regarding CSF-venous fistula as well. We heard about fibrin glue, CT-guided and endovascular embolization. My question is, if you plan to do the fibrin glue and you hit the vein, what do? I had one patient who used Glubrane in the end because we didn't want to inject the glue into the venous system. But is it feasible in your opinion, or would you rather pull back and do the fibrin glue?
So I showed examples there where we have had intravascular spread, and most of the time the fibrin will clog in that vein. Sometimes we have seen it, like I showed those examples of tiny asymptomatic silent PEs. We see that with embolization as well. We obviously monitor the patient if that happens, but that's why I said we also don't just give 4 mils of fibrin in the foramen. We do it as a staged. We give a little. We make sure we do test air and epidurogram contrast, and we move the needle appropriately depending on what we're seeing our spread being. We haven't had any adverse effects from this.
Thank you.
So one question from Florian Forst.
This goes to Professor Schiebing. Just a technical question for your endoscopic technique. Did I get it right that it's a strictly extradural approach, or you go transdurally as well?
No, it's strictly extradural, but because it's a 30-degree angled scope, you can actually look underneath the dura, underneath the dural sac. And that's why you can visualize the dural tear from the outside rather than the inside.
And do you try to squeeze a piece of Tacocil inside from intradurally, or you just patch it from extradurally?
We try to squeeze it through the tear, but again, we've done it less than 10 times, I think. So, but tomorrow at the very end of the day, there'll be a talk about that. From the experience from South Korea, where they've treated quite a few patients that way.
Thank you.
So, one more question from Mark Mamluk.
Just a comment on the question regarding when should you see improvement from patching. at least in our experience, it's usually not immediate, and it can be up to about a couple weeks or so, particularly for the spontaneous leaks. I think if someone recently had a dural puncture and then you do a patch, I think those patients can respond the next day, but at least in our experience, it's usually not the next day.
You know, I think it's just a different mechanism, right? When you place that blood patch, right, you basically introduce a hematoma in the spinal canal and the pressure will go up. So I think a lot of patients have an immediate effect, like what Dr. Urbach talked about. But I think there also can be a bit of a delayed effect, like maybe some inflammation around the dural sac, some scar formation that the CSF, you know, might still be leaking, but just doesn't escape into the soft tissues anymore. I think it can be kind of bimodal. I tell patients, if you're not any better after 2 weeks, at least you don't have to take precautions anymore after your blood patch.
Yes, I have a question to Dr. Meyer. You open a new field with that azygos vein stenosis, and you said it's really important to image the venous system, the azygos vein system, using iron oxide particles. Unfortunately, they are not allowed in Europe, so that makes a difference. For if you do an angiography of the azygos vein system, we sometimes have the impression there could be also valves, venous valves, vasospasm. What would you say if you have the MR venograms and the angiograms? Are they compatible, or is it if you inject via the catheter, you feel the spasm that's different from the venogram from MRI perspective?
We found that the MRV is correlating very well with the angiogram. The question, though, is do we see sometimes azygos veins which are looking narrow, but in reality, you do the angiogram, there is no narrowing. That can happen, and that has happened not just with azygos, but also in the internal jugular vein and SVC. And we tried pressure measurements, which may or may not be helpful, not very helpful in reality. So there's no convincing answer. So there is good correlation, but there are some false positives, yes.
Who use MR venograms in Europe? It's not allowed. I think it could be an off-label use. Is there anyone in the room who use MR venograms with iron oxide particles?
And without iron oxide particles?
Obviously not, but
in
US, many use it. To the US community? Who uses it in USA? Only
Cedars-Sinai. That's correct. I think other centers I know they use CTV to a certain extent, and it's quite good. We chose MRV because number one, it's less radiation. Number two, we thought it would be a good depiction of it, better than CTV, and doesn't rely on the iodinated contrast. So we have not had head-to-head comparison to compare these two, but CTV is an option.
Thank you.
Perfect. One more question.
So we have the persisting observation that the presentation of brain sag dementia or bibrachial amyotrophy is far more common in men than women. So other than the obvious point demonstrated by our panel here that women are constitutionally smarter and stronger than men, does anyone have any thoughts about anatomy underlying this phenomenon?
Who takes this question?
Whoever can answer it.
Yeah, I mean, I don't know either, but it is kind of an interesting observation because some of the other long-term complications, like what Dr. Brouwer mentioned with the bibrachial amyotrophy, that's also much more common in men than it is in women. While, you know, if you take the entire population of patients with spontaneous leaks, right, women are clearly overrepresented. So, you know, that's one of the 25,000 questions that we have about CSF leaks that remains unanswered.
Actually, I think we should not only consider differences in anatomy, but differences in physiology between men and women. They might be more responsible for the differences we find. But I have an extra, actually, I had a different question about the venograms. You do these in lying down position. You do these with ventilation, positive pressure ventilation. Are the venograms you produce not affected by these overextended venous system because of the position and of the positive ventilation, pressure ventilation? So aren't you increasing the severity of the venous fistula by doing the procedure with positive pressure ventilation?
For the MRVs,
it's easier
to
embolize.
The patients
yes.
are awake. They're breathing on their own. They are lying down. There is no upright MRI. But yeah, for the venograms, they're under anesthesia. That's correct.
It makes the embolization easier, of course, but maybe it visualizes. If you don't embolize, you see maybe more than that there is.
But it makes a difference. They do it in general anesthesia, so we get a higher range of CSF venous fistula. We do it with pre-pressurization, get the same. So it's a higher range with that increasing the interthoracic pressure.
And during surgery, it's the other way around. When the patient is under positive pressure ventilation and lying on his belly, you almost don't find these lesions. It's a lesion that is so clearly depicted, it acts like a vessel. You see how the contrast is oozing out like in a vessel in the CT myelogram. Patient is awake. Patient under positive pressure airway ventilation on the belly, I had to push the contrast into the vein because everything, I think it's vice versa. You find it's more difficult to find it in positive pressure ventilation. And even you do it with a forced inspiration in CT. In CT, it's the opposite, I think.
Okay.
Okay.
So one more question here.
Thank you. My name's Casey Martinstone. I'm a patient. I have kind of a two-part question. One is a few of the talks sort of highlighted the differences between the terminology used between institutions. So the type 1, 2, and 3 slightly different across institutions. Is anyone working towards standardization of data and classification systems internationally? And do you think there might be potential for clinical phenotyping of cases based on leak type and location that eventually we might understand purely from the clinical presentation whether the patient is likely to have a specific type of leak or a specific location of leak, and that would streamline their diagnostic process so that they use fewer resources of the healthcare system, for example? Sorry, it's an open-ended question to all of you.
I think Dr. Beck, who gave an excellent presentation about different types of leak, will answer your question.
Thank you, Walter. Of course, we are trying to work to harmonize this. And as Walter has shown you, probably we need to take into account also the anatomical view. And what I really did like is Horst's depiction of the tube tire, that we need to discriminate whether it's an external force or it's a weakness of the tissue. Sorry for not being faster. Of course, we try to get better, but I think we need neurologists to answer this question finally.
So we'll be happy to work on this the coming years.
Manjit, thanks.
Yeah. No, I think what's being said is right, that we do need to define this better. And even though different people are calling it different things, I think at the end of the day, the bottom line is a lot of us know what we are talking about, but there is no doubt there's a need for harmonization. I think the next question speaks to is the presentation of the different types of leaks going to be different, and can we actually start predicting who is going to be in which category? The challenge over there is going to be for somebody who actually works in AI. A lot of, in fact, this is a sidekick for what I do. A lot of my work is, in fact, right now in AI. And we have, for example, phenotyped 2,000 patients with migraine, for example. And the kind of thing we're trying to do is, can we from phenotypes actually start picking out what a person is going to actually have as a final diagnosis? And the difficulty, and I think this is also being relayed, as mentioned in terms of the ICHD criteria, which is really based on headaches only. And we know that, in fact, the study that I was presenting was that only 75% of the patients actually presenting with orthostatic headaches, despite what the literature says. And that's just a bias in literature. What we have is we have a very diverse manifestations. And that is the point I was making in my presentation earlier on. And the question that we're really going to need to answer in the long term is going to be, is there going to be a particular phenotype that is going to go with a particular radiological finding? And the problem is going to be over there that there are going to be huge overlaps no matter what. And with those overlaps, our confidence intervals of saying it is more likely to be this and that are going to be very, very small. So I don't think that is going to really give us the answer in the long term, but something that is going to really need to be done for us to really get to that point. I think the more important issue is that, where we need to do the education is our neurology colleagues often just go to the conclusion that if you do not have an orthostatic headache, you do not have a CSF leak. And that is what we need time to move away from and start appreciating that it's a very heterogeneous presentation. There's also the point that was being made earlier on that not having an orthostatic headache does not mean that you do not have a leak. Yeah, that there's a disjoint between the radiology and the clinical presentation, and that just needs to be appreciated better. And just coming back to a point that was being made earlier on, the reason, just coming back to your question in terms of the reason there's a difference between male and female, I think is actually physiology. I'll give you an example. Men and women, or boys and girls, before menses kicks in, women have the same rates of having headaches, primary headaches, so that's migraine. Because the genetic load is exactly the same. Hormones kick in, and from the time that women are menstruating to the time that they stop, women outnumber men in terms of presentation of headache by a factor of 3 to 1. And yet, the genetic load is the same. Once menopause kicks in, the rates for women drop down again. So what has happened? The load, the genetic load you had is exactly the same in migraine. But what was driving it and what drives that extra manifestation of headache is really the hormonal entraining that is going on. So there's an excellent study that has come out from the East, where they've actually looked at SI presentations in men versus women. And what comes through is, regardless of which type of a leak you have, men have fewer symptoms, present later, and because they present later, very often have poorer outcomes because they're just not being picked up early enough. And they're much more likely to, for example, present with a subdural hematoma. That's because I think the easier ones are actually being missed. And those authors have made the point that you need to be a bit more vigilant in men than women. But again, I think speaks to that. It is probably the physiology, and the physiology that's entraining the brain system is being primed by the hormonal side of things. Those hormonal side of things are making women more likely to present with the headache side of things than men do. I think that's what's underlying the difference between men and women. It's the underlying pain physiology that is actually driving that difference in presentation. No, I agree. I agree. It doesn't explain everything. It doesn't explain everything, but I think it explains part of the things.
Okay, so I don't want to be like a party crasher. There's so many questions again, but I got the sign already that time is up. Shall we stop? Lunch? Okay, so that will wrap up the morning session. So thanks again for all the speakers and for all the participants and asking questions. We see you after lunch. Thanks a lot.